treatment of multiple gingival recession change in the upper and in the lower jaw. So we are speaking about patients that has multiple gingival recessions, let's say in the whole mouth from 6 to 6, and the treatment plan in the upper jaw is divided in quadrant. So we treat all recession between the central to the first molar in one surgical procedure. And so if the patient has recession from 6 to 6, we will manage this recession in 2 surgical interventions, 1 6, 1 6. While in the lower jaw, treatment of multiple gingival recessions is divided in sextant. So we separate the treatment from 6 to 3, 6 to 3, and the last area to be treated is the lower incisors, from lateral to lateral. The reason for the difference is mainly because we have this area that, as we said yesterday, the area of the lower incisors that has such a anatomic characteristics, very, very shallow vestibulum depth, very, very strong muscles, very, very poor amount of keratinized tissue, that the main problem in this area is not to advance the flap only, but to verticalize it. And in order to verticalize a flap, we need 2 vertical incisions that once the periosteum is completely free, can be adapted to the periosteal bed in order to give a flap verticality, even if in this area there is no verticality of the vestibulum depth because of the anatomic characteristics. This is one of the reasons why in the upper jaw, the vestibulum depth is bigger. We have a very, very wide papilla between the 2 centrals that can be used and tunnelized without being elevated in order to make rotation of the flap on the right, on the left side. So theoretically, the 2 interventions in the upper jaw from 1 to 6 to 1 to 6 can also be performed together, same days, one after the other, or one together with the other. While in the lower jaw, the interincisor papilla is very small, and we have the problem of the verticalization of the flap in the lower incisors area. Another very important reason why in the upper jaw treatment of multiple gingival recession is divided in quadrant and not in sextant, it is because the need to add the connective tissue graft is much, much more in the lower jaw than in the upper jaw, because it's more frequent in the lower jaw that we don't have enough keratinized tissue. While in the upper jaw, it's quite frequent that many teeth has good amount of keratinized tissue remaining that don't need any adjunct of a connective tissue. And since the amount of connective tissue graft that we need is less, we can treat more gingival recession together, so 6 instead of 4. That is the maximum we are used to treat in the treatment of gingival recession in the lower jaw. So in the upper jaw, it's 1 envelope type of flap, no vertical incision from 1 to 6. And this flap was introduced in 2000. And in this flap, the imaginary line passing through the mid-buccal surface of the canine is the so-called rotation axis that will influence a lot how the surgical papilla will move, will rotate during the advancement of the flap. In other terms, the whole papilla that we will elevate distal to the canine will also rotate distal during the advancement of the flap, because they are much more influenced by the distal firm point, that is the molar, while the whole papilla mesial to the canine will rotate mesial, because they are much more influenced by the mesial firm point, that is the interincisor papilla. So this is the 2 peripheral teeth that will influence the rotation movement of the surgical papilla in relation if they are mesial or distal, so to the imaginary line passing through the mid-buccal surface of the canine. The rotation axis almost ever change. It's always the mid-buccal surface of the canine. So in order to design the flap correctly, we always start at the level of the canine, where we measure reception depth. We don't have to add 1 millimeter like we do for single. Remember, for single, reception depth +1, and this measurement is done starting from the papilla. In this case, only the reception, no 1 millimeter more, is measured, and the same depth measured with the probe is measured starting from the tip of the mesial and distal papilla of the canine. These are the two endpoints of two submarginal incision, which starts from the most apical extension of the soft tissue margin of the two adjacent gingival recession. It's very important to remember that these incisions are convergent to the canine, because with convergent, you remember that the incision starts from the most apical extension of the adjacent teeth and go towards coronally, apically coronal to the canine. Because you can also theoretically do the opposite, start here and goes apically. But if you do this and you make a more small mistake, so you get longer, you cut the soft tissue margin, and this is a big mistake. While if you start here and you go towards the canine and you make a bit longer, the blade touch the tooth, and the only thing that happens is that you have to change the blade, not to change the technique. Now we measure the premolar, same distance starting from the tip of the premolar, and here you get with a submarginal incision starting from the most apical extension of the second premolar. Now we measure the second premolar, same distance measure starting from the tip of the papilla, and here you get, always with the same direction, convergent towards the imaginary line passing through the canine, the submarginal incision starting from the most apical extension of the molar towards the premolar. Now that we are mesial to the midline, so we are at the level of the lateral, we measure gingival recession to the lateral. The same distance is measured starting from the tip of the lateral, and here you get with a submarginal incision starting from the most apical extension of the soft tissue margin of the central. So this is the flap design, which is made of 5 submarginal incisions, which is directed from the most apical extension of the adjacent soft tissue margin towards the imaginary line passing through the mid-buccal surface of the canine. This submarginal incision, together with the intracircular incision along the gingival recession, make the triangular shape of the surgical papilla. So now, in the treatment of multiple gingival recession, we don't use anymore trapezoidal shape surgical papilla, but we have a triangular shape, and so we have to be very, very precise in the angle elevation, because this angle will rotate during the coronal advancement and must coincide perfectly with the tip of the anatomic desepitalized papilla. And there is no more the 3 millimeters long base of the trapezoidal surgical papilla that allows us to make some minor mistakes. We don't have the safety that we had yesterday, that even if some overlapping between the surgical and anatomical papilla is not perfect, this does not influence so much the outcome, because we are working with triangular surgical papilla that should cover triangular anatomic desepitalized papilla very, very precisely. I don't have to tell you that all of this surgical papilla is elevated split thickness, and this will be done, as you know, keeping the blade as soon as possible parallel to the external surface until the base is reached and the papilla can be completely elevated. Once the whole papilla is elevated, we can use the periosteum elevator, and this can be placed directly inside the probing pocket depth area to make full thickness elevation of the flap until we reach the buccal bone, and we also overcome the buccal bone of a couple of millimeters, and then we go split thickness again. So this is the same type of flap elevation we did yesterday, split, full, split, and this final split thickness elevation, as you already know, is made of two different incisions. One is the deep incision, in which the blade is parallel to the bone, very, very limited in the upper jaw, as we said yesterday. It's only used to separate your muscles of the alveolar mucosa from the periosteum, and as soon as we can, as soon as the alveolar mucosa is detached, we can change the inclination of the blade, and instead of using it parallel to the bone, we start to use it parallel to the inner aspect of the alveolar mucosa to remove the all superficial insertions of the muscles into the inner aspect of the alveolar mucosa. It is this second incision that will allow the advancement of the flap, the rotation of the papilla. But still, there are two areas where we have to improve the mobility of our flap. One is the area of the interincisor papilla that has to be tunnelized with no need to elevate the tip because it's very large. And so if we don't elevate the tip remains and the most coronal anchorage to the flap, and this allows the papilla to rotate and cover the central and the lateral with no need to extend the flap to the contralateral central, and the same is the forcation area of the molar. We can make our flap free from muscles by bending the blade even distal with respect to the forcation area, so to free completely the soft tissue apical also to the distal root of the molar, but with no need to elevate the papilla between 6 and 7, because if we also elevate the papilla 6 and 7, the way the papilla rotate during the advancement of the flap is not the same, and so you will not have perfectly overlapping between surgical and anatomical papilla. So there is some rules in this type of flap that has to be respected, because this was designed in this way and you cannot make too many exceptions. Obviously, the soft tissue coronal to the incision line will be desepithelialized by removing the external epithelium layer with the blade first, and once you get to the tip, you will use your microsurgical scissors. During the advancement of the flap, as I told you, all papilla mesial to the canine rotate mesial and cover the anatomic desepithelialized papilla. All papilla distal to the canine rotate distal and cover the corresponding anatomic papilla distal to the canine. So the flap is done with a series of submarginal incision that starts from the adjacent gingival recession, and they are all directed towards the canine at a distance from the tip, which is exactly the same of the reception depth. This is the flap design, which is only bleeding line, which allows us then to use the blade with the right inclination, which means parallel to the external surface in order to keep the thickness of this papilla minimum and very, very uniform. Papilla elevation ends once the imaginary line connecting the two adjacent gingival recession is reached, and we can use the mobility of the buccal keratinized tissue, which is probable of the two adjacent teeth, to complete papilla elevation. Same thing is done for the all surgical papilla comprised between 1 and 6. Now it's time to start the full thickness elevation of the flap. The first teeth that are elevated full thickness are those with greater amount of remaining keratinized tissue, while the last teeth where the full thickness elevation is performed is those teeth with less amount of remaining keratinized tissue, this to reduce the risk of trauma and of tearing the keratinized tissue of the flap. But as a general rule of thumb, the two peripheral teeth which are always the central and the molars, are always the last teeth in which full thickness elevation of the flap is performed. So among the 4 teeth in the middle, lateral, second premolar, I will start full thickness elevation of the flap of the tooth with greater amount of keratinized tissue, and I will end full thickness elevation of the flap at the level of the tooth with less amount of keratinized tissue. That most of the time is the canine. Once the full thickness elevation of the flap has been done in the 4 teeth in the middle, I can make the full thickness elevation in the peripheral. Otherwise, the risk to tear the tissue in the peripheral aspect of the flap is really very high. Okay, now it's time for the split. Again, this first split is used very, very limited in apical direction, keeping the blade, using only the tip of the blade, in contact to the bone to separate the muscles of the alveolar mucosa from the periosteum. And when you see that the alveolar mucosa, and your assistant has to pull the lip so you can see very, very well, detach from the periosteum level, and you can apply the blade to the inner aspect of the alveolar mucosa, that is the time to start the superficial incision. So this is the deep, very, very limited, use only the tip of the blade until you see that the alveolar mucosa at this level is detaching from the periosteum level. Same is done distal to the canine. So it's like you have 2 different types of flap, one mesial and one distal. And every single time you change from mesial to distal, you also change the angulation of the blade because you have to work safe. So the not cutting surface of the blade must be always oriented towards the peripheral area, and the cutting surface must be always used towards the canine, so to reduce the risk to make unintentional vertical release incision if you use the blade towards the peripheral area. Again, you see here, there is the area where the muscles is inserting into the periosteum. I make this incision very, very deep, keeping the blade parallel to the bone until this alveolar mucosa, you see in 1 second, separates. And when it separates, it means that I can place my blade to the inner aspect of the alveolar mucosa and make the superficial incision. So again, deep, you see here, everything is detached with the only exception at the level of the canine, where still the alveolar mucosa is attached to the periosteum level. So I keep the blade parallel to the bone, parallel to the bone. You see, still attached. Only in this area, the muscles is attached to the periosteum, and with the deep incision, you only cut deep in this area, only with the tip of the blade, and now everything is separated. Now that the alveolar mucosa can be separated from the periosteum, obviously, you completely change the angulation of the blade. You place your blade superficial. This is applied to the inner aspect of the flap, and with the same safe movement in which the blade with the not cutting edge is towards the peripheral teeth and the cutting edge is towards the midline of the canine, you make the superficial cut to remove the all muscles which is present in the inner aspect of the flap. It's very important that you follow the different steps that I try to communicate to you, because in this way the technique becomes very, 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 very standardized. This is more than enough to make the flap completely free to be advanced at the level of the 4 teeth, lateral, canine, premolar, second premolar, but not enough at the level of the molar, not enough at the level of the central, because, as I told you, we have to change the inclination of the blade, go even more distal than the forcation area, even more mesial than the central incisors, to get the tissue here free from deep and superficial incision, even if it's not necessary to extend the incision and open the papilla between 6 and 7. As much as you can, you should always avoid to open the papilla between 6 and 7, because, as I tell you, I told you this changed the rotation movement of the papilla itself. But the blade, first deep, parallel to the bone, and once the tissue can be detached, goes superficial, and this allows the papilla between 6 and 5 to rotate, and once the papilla covers the anatomic, also the recession of the molar is completely covered by the soft tissue with no need to elevate the papilla between 6 and 7 that act as a rotation axis around which you can cover the recession of the molar. Now, same thing is done at the level of the central, where we make a sort of tunnelization of the interincisor papilla, so we make our incision deep, parallel to the bone, to detach the frenulum from the periosteum, to detach the whole muscles from the periosteum, and at least when I can change the inclination, because everything is detached, like now, I make the superficial incision, and this superficial incision will make the papilla rotate, cover the central and the lateral, with no need to elevate the interincisor papilla, which is always a papilla that you should avoid to elevate because of the presence of big frenulum. It's very, very big, the tension you have to do to replace the papilla in position. Root planing, ADTA, if necessary, wide recession defect, also amelogenins. Now it's the time to make the desepitalization. With the blade first, and then the tip is desepitalized with the use of microsurgical scissors. This is the flap. That's the hand, and now we are able to advance and to cover 6 gingival recessions in one surgical time. But it's not said that the keratinized tissue remaining apical to the gingival recession is good enough for being used alone. If the keratinized tissue in one of these tooth is not good enough because it's only 1 millimeter, and this 1 millimeter is placed on the enamel and so remains only alveolar mucosa at the level of the root, we have to give stability to this flap like we did yesterday. If there is only 1 millimeter or less remaining keratinized tissue, we have to add a connective tissue graft. So the application of the connective tissue graft in this surgical procedure is site-specific choose. We are not using connective tissue graft to cover. We are not using connective tissue graft to treat 6 gingival recession. Sometimes we don't need it at all. Sometimes we have to apply it in 1 tooth. Sometimes we have to apply it in 2 teeth. Very, very rarely in 3 teeth. But sometimes it happens. And if this is the indication, the site-specific application of connective tissue graft must be done respecting the whole concept that we shared yesterday, 4 millimeter height, 6 millimeters longer than the width of the recession, and apply with single interrupted 7-0 suture to the base by fixing the surgical knot on the graft. So same concept of yesterday, same technique of harvesting the connective tissue graft. This site-specific application of the connective tissue graft, it's something that really minimizes the numbers of graft and the extension of the graft we need to apply when we treat multiple gingival recession. The suture is always the same. It's a series of sling suture, like the last one we did at the level of the papilla in the single type gingival recession treatment. But in this case, we always start in the periphery of the flap. So the first suture is between 6 and 5, and the second one, it's between the central incisors and the papilla between central and lateral. So to leave the canine as the last suture sling around it. So in this surgical procedure, what we have to remember is that the surgery starts at the level of the canine and goes towards the periphery, while when we are going to make suturing, we start in the periphery and we end in the middle at the level of the canine, because the canine is in the middle of the flap and is the tooth which has much more advancement of the flap. So we want to have the canine to be sutured once the flap is almost in the final position with no tension, thanks to the advancement of the flap in the peripheral area. So also the sequence by the suture, which is always the same sling suture, which is turned twice around the palatal aspect of the of the tooth must be followed in order to make this technique very, very predictable and very, very standardized. I think that one of the main advantages of this technique, and let me tell you, of most of my surgery, is trying to be very standardized. So you don't have to invent anything. You don't have to do other strange type of suture that every single time change. No, same approach, same sequence, and same technique every single time you do. The advantage of this is it is the flap that makes coverage, and the increase in the thickness is the site-specific indication when the keratinized tissue was not enough because of the prominence of the root, because of the lack of keratinized tissue, because of those things. That it's also true for single-type gingival recession treatment. And there is no aesthetic difference between teeth treated with or without the adjunct of the connective tissue graft, because the connective tissue graft is never exposed. So patient will never see which teeth were treated with or which teeth were treated without the adjunct of the connective tissue graft. And this is a very, very predictable procedure in terms of covering, in terms of long-lasting outcome, but also in terms of long-lasting aesthetic outcome. And with time, the only thing that sometimes change again is that the increase in the thickness in the grafted area is a bit more than it was at 1 year outcome, because as we know, as we have already said, this connective tissue graft coming from the desepithelialization of the free gingival graft has the tendency to continue to increase in thickness, even many, many years after the surgical procedure. So this is the long-term outcome. And as we said yesterday, there is most of the cases in which if there is loss of enamel, we have to, let's say, do this restoration before the surgery, but there could be also some situation like when there is some defect of the enamel that goes subgingival, like the situation at the level of this central, in which there is the loss of the scallop outline of the cement enamel junction that cannot be built before the surgery, because this is a projection of the dentin or cement into the enamel with the loss of the continuity of the enamel, and we cannot isolate with the rubber dam this area. And so sometimes we have to combine treatment, restoration before and restoration during the surgical procedure. But the great advantage of this technique is really that since the flap is open from 1 to 6, or if there is no recession, for example, if I don't have any recession in the molar, it doesn't make sense that I extend the flap to a tooth that is perfectly healthy. If there is one tooth, distal, that has no recession, you have to block the flap with one vertical release incision. So the general rule is that this type of flap is always the same, incision convergent towards the canal. But for example, if you don't have recession in the 6, why do we have to extend the flap to the 6 that is healthy? I will make a incision, vertical release incision, distal to the 5. If I have recession 1, 2, 3, 4, I will make same type of flap 1, 2, 3, 4 with only one vertical release incision to the 4. If I have recession 1, 2, 3, and 4, 5, and 6, it's healthy, I will make 1, 2, 3, like multiple type of flap, and one vertical release incision to the 3. So the way we have to block our flap when the adjacent tooth is not involved, because it's not said that we always have gingival recession from 1 to 6, is that same approach, multiple type of approach, is used for the teeth with multiple gingival recession, and if the other teeth don't have any gingival recession, you can block your flap by using one vertical release incision. In this case, there was also the problem of the defect of the enamel, and since the flap is elevated to the old teeth, I can also isolate this area. I can make the opposite to root coverage, but osteoplastic ostectomy in order to expose the suprabony component of the root that allows me for the clamp application. So intrasurgically, I can isolate the enamel that has the defect of the enamel by placing the clamp on the suprabony component of the root that I exposed by means of ostectomy. I did not make any root planing, but I exposed the suprabony component of the root in order to leave root cementum into which the connective tissue fibers can insert. This is the ostectomy, which I personally do once the bone has been thinned with a round bar with the use of the blade, so I don't alter at all the root cementum into which the connective tissue fibers will insert. So now the profile of the bone crest is restored, because when there is this defect of the enamel, most of the time there is also bone that goes too much corner, and we don't have anymore the biological width, namely the suprabony component of the root exposed, and we need to create every single tooth the suprabony component of the root exposed for the connective tissue attachment formation, like treatment of altered passive eruption. Now we can isolate with a clamp, with the rubber dam, we can make the preparation in order to restore the right shape of the cemento enamel junction, which should be obviously done with the use of adhesive material first, composite restoration after, and we have to give the profile of the enamel in relation on how much we want to achieve more or less coverage. If we don't want to cover the central too much, because otherwise the lateral should remain too long, we have to over-counter our composite restoration a bit more, so we are sure that the soft tissue margin will be replaced apical to the over-counter of the enamel with no risk to grow too much in corner direction, because it's not nice to have a central that is shortened at the level of the central incisor with respect to the lateral. So just to tell you how this technique is really very, very, let's say, they can be used in different indications. It's not said that we always mate one flap from 1 to 6. Sometimes the flap is from 1 to 4 because the 5 and 6 is perfectly healthy. And we block the flap at the level of the 4 with a vertical release incision. Sometimes we can make intrasurgical restoration, or we can correct altered passive eruption. We may have a central that is too short, like this, with altered passive eruption that can be increased in length, but at the same time, we can cover the central and the lateral, the canine and the premolar with advancement of the flap. So there is really a great versatility of this surgical procedure that was done at the beginning only for treating gingival recession. Now we know, and we will see today, how much is useful also for the implant therapy. Now the central is good, the other teeth has been treated, we can make the deep and superficial incision in order to advance the flap where there is gingival recession to be treated. And this distal vertical release incision I did was triangular shape, so you are happy, no, you are happy that I did the triangular shape vertical release incision only because one reason. Because since also the adjacent incision is triangular shape and make triangular papilla, if I am able to make the triangular papilla join above the anatomical at the level of the other teeth, I will also be able to make a very, very nice triangular shape vertical release incision that will join with the corresponding anatomic papilla. But in order to understand one complexity of the triangular shape vertical release incision compared to the trapezoidal one, you see that once you overlap the surgical above the anatomical papilla to make it in the final position, you see that there is an overlap because the papilla rotates, because the incision is oblique. While if you make horizontal and vertical, the papilla goes straight through. If you make oblique incision, there is an overlapping between the flap and the adjacent soft tissue when this papilla rotates. This area of overlapping between the surgical papilla and the adjacent soft tissue must be signed with the blade. And now you have exactly the surface that has to be desepithelialized That is the area of overlapping, which is not only the anatomic desepithelialized papilla, but it's also the area where the flap overlap with the adjacent soft tissue. So we have to create a desepithelialization also of this area. That is the area of overlap between surgical, anatomical, and flap. And this makes the overlap between flap and the adjacent soft tissue along very, very long bevel from one side, reduce the risk of scar formation, but on the other side, it's much more difficult because it should be done very, very precisely, like an inlay technique, because it should be a perfect overlapping between the oblique incision and the adjacent soft tissue. So the versatility of this technique means that whenever it's necessary, you can add vertical release incision if one of the adjacent two don't have gingival recession. Means that you can also advance the flap or apically position the flap, for example, if you have altered passive eruption. But the flap design is always the same, oblique incision, directed towards the midline, passing through the canal. Again, in this case, site-specific use of a connective tissue graft at the level of those teeth that don't have enough keratinized tissue remaining. And we are speaking about, in this case, the canine and the premolar. The apical corner dimension of the graft is always 4 millimeters, no more, while the mesial distal dimension obviously will include both the mesial, the distal papilla, and the papilla between the canine and the premolar. As I told you, don't close the palate immediately. It takes time, you lose time, you leave the buccal flap too much open, do it at the hand, remove the fatty and glandular tissue, make the desepithelialization starting in the middle, so you have half of the graft to keep it firm with your fingers. Use one new blade to make the horizontal desepithelialization, and don't forget the vertical desepithelialization where you did the bevel. For sure, an incision that is bevel always is the corner one, because this allows me to start the grafting procedure very, very close to the soft tissue margin with no risk to create gingival recession at the level of the adjacent teeth. So the desepithelialization is performed extraorally. This is the vertical desepithelialization that is done with a blade perpendicular to the underlying bed. And this is the thickness of the graft that we use today, that is no more than 0.5, 0.6. But very, very uniform thickness, very, very good quality of this graft that allows this graft to be very, very well applied to the prominence of the root, to the interproximal papilla area, and to the prominence to the next root, with very, very good adaptation and very, very reduced amount of suture material, 370 suture material to work as a barrier and to protect the flap from shrinkage because of the very, very small amount of keratinized tissue. If one vertical release incision is performed, this has to be closed first, like we did yesterday, surgical above anatomical papilla from the most apical extension of the vertical release incision to the adjacent soft tissue. If the adjacent soft tissue is attached gingiva, we don't need to take any periosteal anchorage, but we can use a very, very small needle and get immediately for the flap to the adjacent soft tissue without getting periosteal anchorage, and so reducing the risk of scar formation. The vertical release incision must be closed completely before getting to the papilla. The way we close the papilla is always the same. The interincisor papilla is always anchored to the papilla between central and lateral, is always anchored to the interincisor papilla that was never elevated but only tunnelized. So to establish how much we want to cover the lateral and how much we want to cover the canine in relation to the objective and to the aesthetic parameters. And the last tooth that has to be treated in terms of coverage, it's always the canine, but at the end, the canine is almost completely covered. And so this final sling suture is really very, very passive. And this allows the very, very small amount of keratinized tissue of the canine to cover completely the connective tissue graft and to avoid any graft exposure, even with time. So this is really the great advantage of this procedure, that can allow you to treat in one surgical time different clinical situation and can be very easily adapted to different situations. So the central was treated as altered passive eruption, lateral canine premolar was treated for covering gingival recession. Now the buccal flap is closed, so we can take our time to close the palate. Most of the bleeding is completely solved, so we can use our collagen sponge, which is stabilized with an horizontal mattress suture, starting from distal to mesial, apical to the collagen sponge, and it's crossed above the collagen sponge in order to stabilize it and to reduce the risk of destabilization of the blood clot if the patient touched this area with the tongue in the very, very first healing period. The only reason why we add this collagen sponge is to avoid early bleeding if the patient, for example, during the night can touch the wound area. So this is the healing where you don't see any difference in color, texture, and surface characteristic, but what is nice is the central was treated because of the defect of the enamel, and so it was increased in length, while the lateral canine premolar and premolar was treated with a coronal advancement of the flap, and distal to the premolar, you don't see any sign of the vertical release incision because this was very, very minimized, and there was a very, very precise closure with no periosteal anchorage along the vertical release incision. This is the central that was increased, altered passive eruption with defect of the enamel, while the other teeth were treated with a combination of composite restoration and mucogingival surgery.